Guys, welcome back to our channel. Today we are going to discuss about the case history in periodontology. So first of all, what is the importance of case history? First and most important step, correct diagnosis leads to the correct treatment plan. Proper clinical and radiographic examination is must. So first of all, in case history, the name is important. Helps to develop the bond with the patient, a rapport with the patient, helps in communication as well as to maintain records. Second is the age of the patient. Age is important as some diseases are more common in young patient and some diseases are more common in old age. So first of all, aggressive periodontitis is more common in young patient and chronic periodontitis is more common in old patients. Wasting diseases like attrition and abrasion is more common in elderly. Some other wasting diseases are abfraction and erosion. Gender, male or female. Localized aggressive periodontitis is more common in females, while osteoporosis, that is postmenopausal women, it is more seen in postmenopausal women. It is due to decreased bone density due to decreased estrogen levels. Social status, it is also important. Economically sound and socially well placed, less dental problems. If a person is more economically sound and socially well placed, there are chances that the person may be having less dental problems. Not well placed, poor oral hygiene, and there will be ignorance and fewer visit to the dentist. So our recall depends upon the social status of the patient. In social status, education also comes. Next is the occupation. Occupational stress like attrition. Occupational stress can cause attrition, dental and periodontal problems. People working in chemical factories can be more targeted for erosion as well as dentinal sensitivity. Healthcare workers are more prone for transmissible diseases like HIV and hepatitis. The next important thing is the address, which helps in the communication to maintain the record as well as to know the geographical distribution of diseases like dental fluorosis. So first of all, the first thing we should note is the chief complaint of the patient. The chief complaint should always be in the patient's own words. It should be in chronological order as well as descriptive as possible. For example, we can say the patient complains of sensitivity in lower left back region since 1 month, and it's aggravated and or triggered by cold foods and relieved by hot foods. So this can be the chief complaint in patient's word. Next is the HOPI, which is nothing but history of present illness. It should be in the clinician's word, clinician's word. That is the things we have seen clinically. That is what is the onset, what is the location, duration, character, aggravating factors, relieving factors, timing, and severity. First of all, history of present illness includes onset. When did it start? It started 10 months back, 1 month back. Location. In endo, there is sharp and easy to locate pain, but in periodontology, we get dull and gnawing pain and cannot usually localize. Duration, for how long the pain is there. Character. Is it sharp shooting or it is a dull pain? If it is sharp shooting, it's a pain related to endodontics, and if it is a dull pain, it is related to periodontics. Aggravating factors, factors which increase the pain. Relieving factors, factors which relieve the pain. Timing and severity. For how long does it last? Perio pain usually stays for a variable duration without any stimulus and dull in nature. So in periodontology, the pain stays for a variable duration as well as without any stimulus, and it is dull in nature. Next is the past dental history of the patient. Past dental history is required as we can know the patient's attitude towards past dental treatment. Frequency can be noted of past dental visit, what are the previous treatment are done, and what are the reasons for loss of tooth. Also, untoward complications, if any complication are there related to dentistry or the products used in dentistry, we can know about that. Next is the medical history. Medical history is important as systemic condition for which the patient is under treatment and medications. Major illness, history of hospitalization. What we should include in his medical history? If is there any major illness or history of hospitalization, injuries to the orofacial region, example injury to the chin, temporomandibular joint problem, trauma to the teeth, devitalization. What are the medications going on? For example, some drug interactions, drug-induced gingival enlargement, anticonvulsant, calcium channel blockers, and immunosuppressants causes drug-induced gingival enlargement. Is the patient having allergy towards any of the following ingredients or substances? Immunization and blood transfusion, high risk of transmission of disease. So is patient have undergone recently any blood transfusion or immunization? Next is the family history. Family history is important as we can know systemic diseases like diabetes have genetic factors involved. So inquiry into presence of disease states in the family is essential. Next is the personal history. Personal history includes dietary habits and adverse habits. Dietary habits includes patient is on a well balanced diet or well nourished, and as well as adverse habits include like patient eats any pan, tobacco, betel nut or any other deleterious habits. Oral hygiene measures in which toothbrush like medium, the toothbrush the patient uses like medium, soft or hard. Okay. Toothbrushing technique, mainly patient uses vertical technique. Which toothpaste, is it fluoridated or not? Fluoridated or not? Interdental aids are used by patient or not? Tongue cleaning habits are done by patient or not? How frequently toothbrush is replaced, it is also very important. So these are all the questions which we should ask the patient related to oral hygiene measures. Next is the hard tissue examination. Now we have to start with the hard tissue examination. First of all, how many number of teeth are present? Imagine 26, 28. Caries or decayed teeth. Examine with explorer and mention class. So we have to write occlusal caries or XYZ caries with respect to 1, 2, 6, 7, 7, 5, class 1 caries, class 2 caries. So we have to mention that. Okay. Next is the missing tooth. So we can write missing tooth with respect to 6. Next is the filled and mention type of restoration. So silver amalgam restoration with respect to 6 and 7. Stains and deposits. We can use the debris index as well as the calculus index to measure the debris, stains and deposits, that is calculus. Next, we will move towards wasting diseases. According to Grippo, classified wasting diseases into 4 categories: attrition, abrasion, erosion and abfraction. So first of all, in 2004, so attrition is nothing but the loss of tooth structure due to tooth contact during normal or parafunctional masticatory activity. As we can see here, the loss of tooth structure due to tooth contact during normal or parafunctional masticatory activity. Abrasion, the pathological wear of tooth substance due to biomechanical frictional force, example toothbrushing. So this is nothing but abfraction. This is nothing but abfraction. It can be caused due to biomechanical frictional. If it is caused by tooth to tooth, it is known as attrition. Next is the erosion, the loss of tooth substance due to dissolution by acids of intrinsic or extrinsic origin. Example gastric acid or dietary acids. As we can see here, there is erosion. As we can see here, this is erosion which can be caused by gastric acid or dietary acid. Next is the abfraction. Abfraction is nothing but the pathological loss of tooth substance caused by biomechanical loading forces due to tooth flexure leading to fatigue of enamel and dentine at a location away from point of loading. So we can see abfraction lesion. There are 3 types: wedge shaped. Wedge is nothing but a tent shape like structure. Next is the saucer shaped, it's curved, and third is the mix shape. like it's not saucer also and it's not tent also. So wedge shaped abfraction, saucer shaped abfraction, and mix shaped abfraction. Hairline cracks, striations, saucer shape, semilunar, and cusp tip invagination. So to summarize, attrition, abfraction, erosion, and this is abrasion. Okay, triangular defect is abfraction, this is abrasion. Now the next thing is occlusion, which we should note in case history. Angle's classification of malocclusion is very important. Food lodgement and food impaction. What is the difference between two? Food lodgement is the passive accumulation of food, while the food impaction is nothing but forceful wedging of food into the periodontium. There are two types of vertical food impaction due to open. There are two types, that is vertical food impaction and horizontal or lateral food impaction. Vertical food impaction occurs due to open contacts and irregular marginal ridges, and horizontal or lateral food impaction occurs due to gingival inflammation, causes enlarged gingival embrasure, and lateral pressure from lips, cheeks, and tongue causes food impaction. So vertically it can be caused by open contacts or irregular marginal ridges, and horizontally it can be caused by gingival inflammation. So the food gets impaction from lips, cheeks, and tongue. Clear? This is vertical and this is horizontal food impaction. Food impaction, as we can see, and causing the decay. Plunger cusp, it is one of the important term. Cusp that tend to forcibly wedge food into the periodontium. Here imagine there is a cusp which is forcibly pushing the food into the periodontium. So this cusp will be known as plunger cusp. Plunger cusp. Next is the proximal tooth contact. There are mainly two types of tooth contact, normal proximal contact or open contact areas. Normal proximal contact do not allow any food impaction in between the teeth. So this is a tooth and this is the another tooth. As we can see, there is a slide. There is a slide area only where the contact is not present. Open contact areas are usually associated with food impaction and gingival inflammation. In open contact area, as we can see in midline diastema, it is related to food impaction and gingival inflammation. Open contact area can be found commonly in malaligned teeth or in proximal caries where contact has been lost due to tooth decay. So in case of malaligned teeth, we can see open contact area, as well as in the case of proximal caries, that is caries respected to the mesial or distal surface. Next is the pathological tooth migration. Tooth displacement that results when the balance among factors that maintain physiological tooth position is disturbed by periodontal disease. So the physiological tooth position has been disturbed. It is known as pathological tooth migration. Presents as facial flaring, extrusion, there will be more flaring, there will be extrusion, that is outward movement of the tooth from socket, rotation of the tooth, diastema, and drifting of affected teeth, that is moving of the affected teeth. Most common is the facial flaring and diastema. The two more common pathological tooth migration are facial flaring and diastema. Next is the posterior bite collapse. One of the reasons for pathological tooth migration: increased occlusal load and reduced periodontal support in case of secondary trauma from occlusion. There is an increased occlusal load and PDL is supporting less. So occlusal load has increased but the PDL support is decreased in case of secondary trauma from occlusion. So in the case of TFO, trauma from occlusion, forces from tongue, lips and cheeks put forces on teeth sufficient to cause pathologic tooth migration. As you can see in this picture and this picture, this is the upper lip, tongue, mastication, occlusal forces, lower lip habits, all this affects the tooth. So here is my tooth. So it is getting trauma from occlusion, which is causing the posterior bite collapse or tooth migration. Next is one of the most important tests, that is Fremitus test, which is which is a test performed to detect trauma from occlusion. Abnormal forces from opposing teeth may lead to slight discomfort to severe pain. Occlusal disharmony is due to traumatic occlusion or trauma from occlusion. Fremitus test is used to detect trauma from occlusion. Vibratory pattern of teeth is observed when they are brought into contact. A dampened index finger is placed over the buccal and labial surface of the maxillary teeth. Patient is asked to tap teeth together in maximum intercuspal position and grind systematically in lateral protrusive contact position. So what we have to do, we have to damp the index finger and keep it on the buccal and labial surface of the maxillary teeth. Patient को बोलना है कि tap करे teeth को together for the maximum intercuspal position and grind करना है, मतलब chew करने बोलना है in lateral protrusive contacting position. So we have to keep our finger like this, and if we don't feel vibration, if vibration is not felt, so we can say Fremitus test is negative. If vibration is felt, so we can say Fremitus test is positive. And from this we can infer three things, that is class 1, class 2 or class 3 trauma from occlusion. Class 1 is mild vibration or movements are detected. Class 2 is easily palpable vibration but no visible movements. And class 3 is visible movements with naked eye are visible. So clear, class 1, class 2, class 3. Next is the soft tissue examination. Soft tissue examination, we have to examine the labial and buccal mucosa, tongue, soft and hard palate, floor of the mouth, vestibular depth and frenum attachment. Examination of gingiva, which is one of the most important topic in this soft tissue examination. The color of the gingiva, the normal color of gingiva is coral or pale pink. Pigmentation may be present. As you can see, it is coral or pale pink. In chronic periodontitis, it becomes reddish pink or bluish in color, and in acute periodontitis, it becomes bright red in color. So in acute periodontitis, how it will appear? Very bright red, and in chronic periodontitis, it will appear reddish pink or bluish in color. Next is the contour of gingiva. Contour of gingiva is this contour of gingiva. In healthy gingiva, it is scalloped with knife edge. How it is scalloped with knife edge? So this is the edge, we can see scalloped, and it appears knife edge gingival margins that adapt closely around the teeth. So in normal gingiva, it is closely adapted, knife edged, okay, that adapt closely around the teeth. Papilla is pointed and pyramidal. In normal gingiva, the papilla is pointed. The papilla is pointed and pyramidal. How it appears? Pyramidal. One thing to note, that the papilla in anterior region appears pyramidal, while in the posterior region it appears tent shape. How it appears? Tent shape. Remember this, we have to write this in case history. Papilla is pointed and pyramidal, fills interproximal areas. In case of space between two teeth, it is saddle or flat shape. As you can see, if there is any space, it has become flat. How it has become flat? Else it would have been pyramidal or tent shape. Pre of inflammation, that is rounded gingival margins due to edematous and fibrotic changes. Papilla is bulbous, flattened and blunted. So here we can see before inflammation, papilla is bulbous, flattened and blunted, while the margins have been rounded. It's not knife edge. It's not appearing as knife edge. It's appearing as rounded due to edematous. So in diseased condition, we can write, in normal condition we can write the contour is scalloped, and interdental papilla, as we have discussed earlier, it could be pyramidal or tent shape, if in anterior pyramidal and in posterior tent shape. In diseased condition, we can write accentuated scalloped, or we can write blunted. And interdental papilla, we can write smooth or rounded. ठीक है. or flat. Consistency of healthy gingiva is firm and resilient. Firm and resilient in normal gingiva can be checked by palpating with side of a blunt instrument. How we can check the consistency? By side of a blunt instrument. In the case of gingival inflammation, we can see soft edematous spongy gingiva dents readily when gently pressed. As you can see, it is inflamed. As we can see, it is inflamed. So edematous appearance can be checked by any blunt instrument. We have to keep the instruments here for 10 to 15 seconds. So if the gingiva gets indentated, means it is inflamed. In the case of chronic inflammation due to fibrotic changes, gingiva is pink and stippled but bleeding on probing present, firm and hard. In the case of chronic inflammation, BOP, bleeding on probing is positive and the consistency becomes firm and hard. Marginal gingiva gets easily displaced from the tooth margin with a light air blast indicates destruction of gingival fibers that support gingival margin. So as we can see in chronic inflammation, the marginal gingiva or free gingival margin gets easily separated or destructed from the tooth. So it is because the gingival fibers are not in place. Next is the surface texture. So surface texture appears stippled appearance, that is orange peel appearance. Continuous elevation and depression is known as orange peel appearance or stippling. It's important. So in normal gingiva, as you can see here, stippling is present. In this, stippling is absent. Microscopic elevation and depression due to connective tissue projection within the tissue. Dry the gingiva. How to check the surface texture? Dry the gingiva with cotton and view it under broad daylight. Light from all directions required to see it clearly. Stippling is absent in infancy, appears in about 5 years of age, increases until adulthood and frequently begins to disappear in old age. So it appears in 5 years of age and disappears in 60 or plus years of age. Loss of stippling is early sign of gingivitis. So we can write in normal conditions stippling is present. In disease condition, stippling is absent. The one of the most important diagnosis from stippling we get is the marginal gingivitis. Is the gingivitis marginal or diffused? If stippling is absent, it is diffuse gingivitis. If stippling is present, it is marginal gingivitis. So the next criteria is the size of gingiva. Check for normal size, enlarged in the case of gingival enlargement and reduced in the case of gingival recession. So in the case of gingival recession, the size gets decreased, while in the case of gingival enlargement, it gets increased. Enlarged in gingival enlargement, reduced in gingival recession. The position normally present at 1 to 2 mm coronal to CJ. 1 to 2 mm coronal to CJ. Apical migration, that is normally the gingiva is present 1 to 2 mm coronal to CJ. If there is apical migration of gingiva, gingival recession, coronal position, it is apical migration from gingiva is termed as gingival recession. Coronal position is termed as gingival enlargement. So this is the CJ. If it goes up, means gingival enlargement. If it goes down from CJ, it is gingival recession. gingival enlargement में CJ ऊपर आ जाएगा, gingival recession में नीचे चला जाएगा. Now gingival exudate, which is also known as suppuration. Discharge from gingival sulcus indicates disease activity. Put slight pressure on the lateral surface of the gingiva. White purulent material oozing from gingival sulcus indicates presence of exudate, that is suppuration positive. This is bleeding on probing. A mild edematous gingivitis. A probe has been introduced at the bottom of the gingival sulcus. B is the bleeding appears after a few seconds. Bleeding on probing, spontaneous within 10 seconds, immediate within 30 seconds and delayed after 30 seconds. So BOP can be measured as termed as spontaneous, immediate and delayed. Spontaneous within 10 seconds, immediate within 30 seconds and delayed after 30 seconds is an indicator of tissue inflammatory response to bacteria. it is the first sign of gingivitis, that is bleeding on probing. Chronic inflammation. In the case of chronic inflammation, gingiva may appear fibrotic, but inflammation may be actively present in the gingival sulcus and junctional epithelium. In the case of smokers, reduced bleeding on probing due to effects of nicotine. In acute gingivitis, bleeding may occur even after slight provocation like short burst of compressed air. So in acute gingivitis, if I have a burst of compressed air also, there will be bleeding. Embrasures. Embrasures present cervical to the interproximal contact area. Where are the embrasures present? It is present cervical to the interproximal contact area. So if this is my tooth and this is my another tooth, so this is my contact area, so it is present cervical. This is my embrasure. Embrasure is also known as spillway. Embrasure is also known as spillway. So according to Norland and Turnow classification of interdental papillary height 1998, the normal interdental papilla class 1, class 2, class 3. The normal interdental papilla occupies the entire embrasure space apical to the interdental contact point. All the interdental space present apical to the interdental contact point, that is normal. The class 1 tip of interdental papilla is located between the interdental contact point and level of CJ on the proximal surface of tooth. Class 1 में कहाँ होगा? This is my cemento enamel junction in the case of class 1, and this is my point of contact. So my interdental papilla will be located between these two position, that is contact point and CEJ के बीच में. ठीक है, contact point and CEJ के बीच में. Class 2 में the tip of interdental, we have to notice this, we are talking about the tip of interdental papilla. In the class 2, interdental papilla is located apical to the level of CEJ. If the tip is located apical to the level of CEJ, we will tell as class 2. Tip if the on the proximal surface of the tooth but coronal to the level of CJ mid-buccally. Tip of interdental papilla is located at or apical to the level of CJ mid-buccally. So we are talking in the mid-buccally. This is my buccal surface, this is my lingual surface. So if the interdental papilla is near the CJ but it is near the mid-buccal area, so it is class 2, and if it is apical to the mid-buccal area, it is class 3. As you can clearly see in this image, based on 3 anatomical landmarks, that is interdental contact point, coronal extent of proximal CJ and apical extent of facial CJ, which is nothing but buccal CJ. Interdental contact point, level of interdental papilla, facial CJ, that is buccal CJ. So interdental contact point and level of interdental papilla class 1 रहेगा, class 2 रहेगा, and apical to this is class 3 रहेगा. Simple. This is my mucogingival junction between the attached gingiva and alveolar mucosa. Now most two important terms, that is McCall's festoons and Stillman's cleft. McCall's festoon, as the name suggests, is a life preserver shaped rolled margins of the gingiva where the gingiva shows fibrotic properties. As you can see here, it is appearing rolled margins, so it is known as McCall's festoons. Next is the Stillman's cleft, which is the first sign of recession. As you can see here clearly, it is appearing like ESA. Triangular shaped cleft, as a cleft is nothing but a breach in the continuity. As we draw mountain, this is the cleft. First sign of recession, formation of small groove in the gingiva. This term for the cleft like recession. Cleft like recession. This is known as Stillman's cleft.
So this was all about today. We discussed the case history part 1 in periodontology. So in the next part we will see the examination of the periodontium. We discussed many things in this. First of all, We discussed importance of case history, name, age, gender, social status, occupation, address, chief complaint, history of present illness, past dental history, medical history, significance of family history, personal history, oral hygiene instruction, heart tissue management, wasting diseases, occlusion, proximal tooth contact, pathological migration, Fremitus test, how it is done, soft tissue examination. We have started with examination of gingiva. We have seen various properties of gingiva, and in the last we saw interdental papilla. And we saw two important terms, McPear's festoons and Stillman's cleft. In the next video, we will see the examination of the periodontium, that is scale, gingival recession, how to measure pocket depth, etc. Thank you. Keep visiting. Stay tuned for part 2.